Good afternoon, everybody. Welcome to Grand Rounds today. It's my pleasure to introduce Dr. Eric Vargas. Dr. Vargas is board certified in internal medicine, GI, and obesity medicine. He attended medical school at Penn State University. He then did his internal medicine residency at the Mayo Clinic, where he stayed to do fellowships in GI and advanced endoscopy. And he also, during his time there in training, received an MS in clinical and translational science. He's currently an assistant professor of medicine at Mayo and a consultant in GI and hepatology. He's been extensively published in the arena of metabolic and bariatric endoscopy, and he very kindly has accepted our invitation today for a review of metabolic and bariatric endoscopy. And please join me in virtually welcoming Dr. Eric Vargas.
Well, thank you, Dr. Hallberg, and thanks to Amber as well to help coordinate being here today and share a little bit of about what I do and what my real passion is. But it's really the intersection between innovation and obesity, metabolic and bariatric endoscopy. When I'm not doing EUS and ERCP, which is the bulk of, I would say, 75% of my clinical volume, the rest is kind of all into metabolic endoscopy within clinical trials and clinical care. So little disclosures. First, I have some research funding from Boston Scientific, internal funding from Mayo Clinic, and throughout the talk, I'll be discussing a little bit of off-label applications of these therapies, mostly as a view into the future or what's coming down the pipeline within the next year or two. So learning objectives will review the use of metabolic and bariatric endoscopy in primary obesity, mainly at the endoscopic sleeve gastroplasty, as well as gastric fundal mucosal ablation. We'll also review the use of metabolic and bariatric endoscopy, or MBE, for the revision of previous bariatric surgery, such as transoral outlet reduction, also called TORI or TOR. And we'll also review the use of bariatric endoscopy in the small intestine to treat obesity and to type 2 diabetes, referred to as duodenal mucosal ablation therapies. So a brief overview. As we all know, obesity is a multifactorial, chronic, progressive, and relapsing disease state. Excess adiposity drives over 200 weight-related conditions, both expand the metabolic side, such as insulin resistance, dyslipidemia, metabolic dysfunction-associated liver disease or MASLD, as well as PCOS. Mechanical factors associated with excess adiposity, such as hypertension, sleep apnea, and chronic joint disease. And it's not surprising that adults with obesity have an associated increase or excess in annual medical costs per patient, roughly equivalent to 172 billion annual expenditures in excess compared to normal weight counterparts. And at this rate, by 2030, obesity prevalence will approach 50% of the U.S. population. Although I'm optimistic that that number won't be as high with the recent introduction of GLP-1 and incretin medications, but that was the latest estimate. And the cornerstone of therapy for obesity still remains behavioral modification, but unfortunately, for most, it's only effective in 3 to 5% of adults with obesity. A lot of them tend to regain their weight or not reach the weight loss thresholds they desire. Obesity overall is a multidisciplinary disorder. It's so nice to talk to you about this because it really isn't an organ-specific medical problem. It really has many downstream effects, including over 13 malignancies that can be associated, especially from excess weight. And we can think about how excess weight affects multiple things, like even in my day-to-day, just as a simple of a colonoscopy, it's harder for patients because they're at heightened risk for colorectal cancer from the get-go, but they're also more likely to have a poor colonoscopy prep. Their body habitus makes it more challenging to perform the colonoscopy, which can be quite acrobatic at times. Our nurse anesthetists or us may be less comfortable sedating deeply due to sleep apnea. All this makes the procedure more difficult and challenging, which can really thwart our polyp detection rates, and which ultimately could lead to cancer. But obesity really affects many of the patients we see across many different specialties. So it's really important to tackle obesity as best we can when the time is right. So what do we do for obesity? You know, we all know weight loss improves obesity complications. Really with 10% total body weight loss, that's been a meaningful threshold, which we see some really good, meaningful benefits across the spectrum. Here we have a graph on the left showing what the what weight loss improvement leads. So ranging from 0% all the way to 20%. And this green line here demarks the 10% mark, where we see improvement in patients who had early insulin resistance. We definitely see improvement with glycemic control and diabetes. We see improvement in lipid parameters. We start to see some changes in sleep apnea, but not yet as much. But we also see improvement in fatty changes in the liver. And at higher thresholds, we start seeing some fibrosis regression and improvements in mortality, a complete improvement in these comorbidities such as hypertension. When we used when we look at patients with obesity, we always use BMI because it's a very simple way to capture these patients, but we're trying to move beyond BMI, weight plus hip and waist ratio, or some signs of excess adiposity comorbidities such as hypertension, diabetes, sleep apnea, chronic kidney disease, by using more definitive metrics such as DEXA scans or bioimpedance, we can usually look for excess body fat in a more objective fashion and then pair that with whether they have elevated or low muscle mass, and if they have any signs or symptoms of obesity, again, like diabetes and hypertension. And using this framework, we can identify patients who under BMI may be classified as having obesity yet are actually metabolically healthy without having any obesity, maybe perhaps just overweight. But we can also in turn find patients who are just classified as overweight, but when paired with poor muscle mass or signs of clinical disease, we actually can consider them having obesity at lower BMI rates. And BMI is also, the thresholds are different for those with Asian Pacific ancestry. So that's something to be mindful as well, that the BMI cutoffs vary by race and ethnicity, specifically looking at the Asian population. So what do we do? What else can we do besides diet and lifestyle? We know it's a problem. We know that weight loss, eating less and moving more works, but what else can we do? Especially when we need greater than 10% total body weight loss for metabolic improvements, approaching 15 and 20%. Well, we know that metabolic and bariatric surgery works. There's tons of evidence that it is a gold standard treatment for obesity, but it is invasive. There are some operative risks, and there's some prolonged downtime from recovery from surgery. There can be some long-term adverse events from bariatric surgery. Specific to the sleeve gastrectomy, patients can have de novo reflux. They can also have, rarely, sleeve stenosis, which leads to regurgitation and difficulty eating, which could in turn lead to a conversion to a roux, or undoing of the sleeve by endoscopic means. There's also the Roux-en-Y gastric bypass that can be complicated by GJ or outlet stenosis, dumping syndromes, internal hernias, malnutrition, persistent recurrent bacterial overgrowth. And really with these surgeries, there is lifelong modification on how we eat and drink. It's really not optional. It's kind of almost forced diet changes after the surgery. And honestly, a bit of it may be patient perception about these risks. They often outpace the reality of how risky they are, but that's why only 1 to 2% of those that are eligible for bariatric surgery actually undergo. So that becomes a problem. So a lot of patients that would benefit maybe are worried and do not undergo surgery. Now we have these medications that work really well. They've really transformed the obesity landscape and management. And when they're taken, they work exceedingly well, losing 10, almost 20% total body weight loss. But there can be cost and coverage issues. Not everybody may have it. Some patients have severe gastrointestinal and constitutional side effects from these medications. There's a not ignorable 25% non-responsive rate where patients tend to lose less than 10% of their body weight. And we all know that it really must be taken for life to really maintain the effect. The discontinuation rate is 60%, and I've seen up to 75% in some studies that patients discontinue. And what happens? So when we know from the step 4, the semaglutide, and the SURMOUNT-4 study for tirzepatide, that patients lost a lot of weight, and then when they were randomized to receive a placebo or continue on the medication, those that switched to the placebo almost regained 75% of their weight lost at 1 to 2 years post being switched to the placebo. So this combination of either patients not 25 being non-responders, upwards of 50% discontinuing the medication, and upwards of 75% weight regain in 2 years is a very troublesome combination. When we think about all the patients that qualify for the medication, and on top of it, let's maybe when we add the ones that can't even get access to it. So it may not be the end all or the answer for every patient, these new GLP-1 and combo medications. Here's a projection shows that basically almost 2 years after the medication is discontinued, it's projected that basically all the patients will end up regaining all their lost weight 2 years after they've stopped. That's, again, a very troublesome statistic, and I hope they're wrong, especially if we can do something about it. But that's something that should not be, it should be discussed with patients when we're starting these medications. And overall obesity, there's a heterogeneity in the response across the spectrum, from lifestyle therapies, surgery to medications. Here we have 6 kind of graphs. I'll start in the top left. We have here the proportion of patients who've reached levels of weight loss on the y-axis, and on the x-axis is the proportion of patients that have lost anywhere from 0, 5, 10 to 15% total body weight loss. On the top left is lifestyle intervention. We can see that there are patients that do end up losing surgical levels of weight loss with lifestyle therapy alone, and there's also patients who gain weight despite their best efforts. We see the same variability in response with endoscopic interventions, where not everybody loses surgical degrees of weight loss. And I'll tell you, from seeing patients for over a decade now, from when I started residency, there are patients that still gain weight 10 years after they've had these procedures. So it's not an only positive side for endoscopic interventions. Same thing for surgery here. We see incredible degrees of proportion of patients who achieve surgical levels of weight loss, much higher than lifestyle interventions. But there's also, I've seen patients who've regained all their weight after Roux-en-Y gastric bypass. That does happen. We see that heterogeneity across the medications as well, and we'll continue to understand how they really behave in clinical practice in real world studies over time. So how do we approach patients? So this is a very simple kind of schematic on purpose. We have a patient with obesity or pre-obesity, if you use different metrics. You have the patient be evaluated by an obesity specialist or someone who has an interest in obesity. You look for comorbidities to establish the burden of disease. You counsel, cornerstone of therapy, and then you assess their readiness for an extra intervention, such as obesity medications or metabolic and bariatric surgery, depending on their BMI range, insurance, and access and willingness or acceptance of these therapies. And if patients progress on either side of the spectrum with other therapy, you really have to do something different, whether it's add medications or add surgery or convert to different types of surgeries if that happens. So this is a very simple schematic, but in reality nowadays, given the heterogeneity in response, there's really a lot more we can offer. And this is very complicated, but it just shows how much options really patients have. They can either go to different endoscopic therapies, they can go to medications, and you can add endoscopic therapies or switch medications. You can revise prior surgeries with endoscopic bariatrics on top of adding medications. There's also these emerging endobariatric therapies that I'll talk about a little more, or concepts where we purposely start medications on the medication and do the endoscopic intervention. at the same time as a way to minimize or reduce the chances of them needing bariatric surgery. Because one things I like about endoscopic bariatrics is that we're not burning any bridges. Patients can still, if they need it, progress and get a bypass or a laparoscopic sleeve after these therapies. So it's still possible. Now I'll switch gears for a little bit. Now that I've kind of gone over a little background of obesity, some heterogeneity of response across all the available therapies, we'll go a little bit more in depth on endoscopic bariatrics. And I'll start with a case. So we have a 51-year-old woman with class 2 obesity, complicated by type 2 diabetes, has hypertension. She's here to review obesity treatment options. So you know right there, the patient is engaged and they're ready to lose weight and they're coming to you for options. 2 years ago, she did lose 12% body weight on 2.4 sub-Q semaglutide, but she stopped 6 months after she lost that weight because of heartburn and constipation, and unfortunately had observed a complete weight return over the past year. She's willing to try something else, but she doesn't want to do medications or options, surgical options. So when you're sitting with this patient, what can you offer her as far as endoscopic therapies? We can offer her an intragastric balloon. We can offer her the endoscopic sleeve gastroplasty. You could offer her the vertical sleeve gastrectomy or the endoscopic sleeve gastrectomy or a transoral outlet reduction. I don't know if we have some sort of question function of this presentation, but I'll walk you through this. So the correct answer is B, the endoscopic sleeve gastroplasty. A, the intragastric balloon. It is an effective endoscopy treatment, but it's not the most effective. And once you remove the balloon in 6 months, generally all the weight comes back. I almost look at it as a medication mimetic. It works when it's on, but it does not work once it's removed. And you can only remain in place up to 6 months. There are some balloons that can stay up to 9 months, but once it's removed, there is a higher likelihood of patients regaining their weight. So it's not the most effective option. Then we have the endoscopic sleeve gastroplasty, which is the correct answer. I'll talk about that more in detail. C, incorrect, because that's surgery. D is incorrect because it's just endoscopic, has the word endoscopy, but also has the word gastrectomy. So that's just a question, an answer to confuse you. But we have seen patients refer to it as an endoscopic sleeve gastrectomy, no fault of their own. Gastroplasty is the correct terminology because we're not removing anything out of the body. And lastly, the transoral outlet reduction is an endoscopic approach after patients have had prior room-wide gastric bypass. So what is the endoscopic sleeve gastroplasty? Some basics. It's an incisionless, completely through the mouth for peroral endoscopic procedure. It usually takes about an hour of suturing time under general anesthesia. Same-day discharge. What we do is we place full-thickness sutures into the stomach wall where we shorten and narrow the stomach into a sleeve-like configuration, almost tubularized to the shape of what we say a medium banana. And here's a picture of the suturing device that gets attached to our double-channel therapeutic scopes, where we can do everything through the inside of the stomach, folding or involuting the stomach from the inside. So here's a picture of a stomach before the endoscopic sleeve. If any of you seen endoscopies, you really can't capture how, or unless you're really seeing it in real time, you can't appreciate as much as how big and how deep the stomach here in this photo, but it is large, let me tell you, especially when you insufflate. So we take the greater curvature of the stomach, and using this full thickness suturing device, which is basically like a sewing machine, we grab tissue. You can see here this green forceps device that's grabbing the stomach folds, starting at the level of the incisura, or the very distal part proximal to the antrum, and we pull that tissue into us. So we're folding tissue in, and then we take a bite. See here, we're pulling it in, we take a bite, and we've left the suture now, creating this like accordion-like apposition of serosa or serosa, because this is a full thickness device where the sutures go out and back into the stomach for serosate or serosa apposition. And we continue to take these bites all the way around to the greater curvature of the stomach, where it almost looks like a braided pastry in the greater curvature of the stomach, kind of a rope-like appearance. The sutures are buried within those folds over time. The sutures act really as a scaffolding for remodeling to occur and scarring, and the serosate or serosa apposition occurs, and it after a year, the stomach is much more tubularized and narrow in caliber. And you can see here, there's a purposely left gastric fundus pouch for food to accommodate and empty over time, giving you sensations of fullness between meals. And I want you to remember that we leave the fundus intact because it is a very thin part of the stomach. So it is higher risk for perforations or leak. So early times, they first started to suture with older generation devices, and they found that it was a bad idea, and that actually leaving the fundus intact promoted safety, but also provided a mechanism to induce basically more satiation between meals. So how does it work? The stomach, after being reformed, it provides some sensory motor feedback to the central appetite centers via the vagal afferents or relays. There's impaired gastric accommodation or impaired relaxation of the stomach when food enters, giving you a sense of satiation. It also, we've proven that it delays gastric emptying, so it keeps you fuller between meals as well. Weight loss outcomes from randomized clinical trials, we saw 15% total body weight loss at 1 year. And something that people don't know about this trial is that it was run actively during the COVID pandemic. So despite us losing the ability to see patients in the office during the follow-up period, patients still lost an average of 15% total body weight loss. So one could argue or wonder if the true randomized data would be a little higher if it wasn't during the COVID pandemic. But on the same token, it kind of biased on a little bit of what the more real life scenario would be if patients got this therapy and lost the ability to follow up as intensely as they would from a clinical trial. We know now it's durable. We see up to 5 years of patients keeping weight loss, and roughly over 3/4 of patients achieve this gold standard of 10% total body weight loss at 1 year. A little bit of a historical perspective, when we all started doing endoscopic bariatrics, this is a decade now or so ago, the first benchmark was actually 5% total body weight loss. That was all we wanted. And now, with how successful we've been and with the medications on board, we've kind of moved that benchmark, and we now want 10%. And I would argue we will want 15% total body weight loss in the future as we have better medications come out through the pipeline. So what about comorbidities? Well, we have patients that roughly 50% improvement in type 2 diabetes, either coming off insulin completely or decreasing the amount of medications. Same thing with dyslipidemia, hypertension, and sleep apnea. So across the board, there is some improvement in some rates of complete resolution of comorbidities. Obviously, that tracks with the level of weight loss seen with the procedure. What's the recovery like? So these patients come in, it's completely outpatient, dismissed same day. There's roughly 3 to 5 days of low-grade GI symptoms. I'll tell patients that it is nowhere near the level of nausea and vomiting that you get after starting a GLP-1. Maybe half that degree, but only for 24 hours. And after usually those first 24, you're wondering, is that it? And so it's actually quite nice to do these on patients who've had a GLP-1 before, because they actually aren't as bothered by the symptoms. But in any event, we do a gradual dietary advancement from liquids to soft to solid over a roughly 8-week period. And the liquid diet is mostly to preserve the suturing part of the procedure. It's not geared towards weight loss, but of course some weight loss does occur during this liquid diet phase. There's really no major activity restrictions. There's no long-term medications compared to bariatric surgery. You don't need to inject yourself with vitamins or take oral supplementation for life. because we're not creating a hypoabsorptive state with this procedure. And if you were on any anticoagulation, we generally resume them in 48 hours, but in high-risk situations, we can start them earlier or do prophylactic level dosing much sooner. And that's becoming quite common here as our patients get more serious and complex. What are the adverse events? GI bleeding, less than 1%. Leaks, rare, less than 1%. Severe GI symptoms, also less than 1%. Perforation, what we worry about the most, also less than 1%. And I'll always remember that one case of a blood clot in a case that took 8 hours, and that was the first case they ever did. And so we have to report that one blood clot that occurred over 12, 13 years ago. But fortunately, there's no been published deaths on the ESG to date. What patients are qualified or are FDA cleared? Well, basically anybody with a BMI between 30 and 50, this device is FDA cleared to proceed with an endoscopic sleeve gastroplasty. Patients should consider this as a tool to facilitate that cornerstone of therapy, which is lifestyle changes, increased activity and decreased intake. Reasonable approaches for you to implement the sleeve in your practice. You can do it as a standalone therapy. You can also use it in combination with medications. Our preference has been, there's some early data that the sleeve first and medications later is better, but it's really early. And I wonder if the opposite will be just as true, where you start medications and you use the sleeve as an off-ramp to keep the weight off, or at least a big proportion of it. You can also use it as a step up after medications, after an intragastric balloon, after it's been removed, or after a laparoscopic gastric band therapy in combination. You can also use it off-label after a previous ESG or a previous laparoscopic sleeve, which has seen some weight loss as well. One of the things about, just a reminder that we're not burning any bridges with the endoscopic sleeve. We could always repeat it a year, 5 or 10 years after the initial endoscopic sleeve, but patients can also get a Roux-en-Y or a surgical sleeve if they desire or need one after this procedure. So we're not burning any bridges. Contraindications: untreated eating disorders or untreated substance abuse. Pregnancy, although it's okay to get pregnant 6 months after the endoscopic sleeve. There are some rare situations, essentially esophageal surgeries, or if they have cancer, let's say on Ivor Lewis, that the ESG is not really approved, but it's done off-label in really interesting and rare cases. Same thing with decompensated end organ dysfunction, such as end-stage liver disease or end-stage kidney disease, because we are using this procedure as a bridge towards kidney transplant, or as after a liver transplant too, by the way. So not only before kidney for eligibility, also before after a liver transplant for mast-cell-related cirrhosis. And we are starting a small practice of using this procedure as a bridge to heart transplant, or to get patients on LVAD therapy at a healthier weight, which has reversed their level of heart failure. In some cases, gotten off the LVAD, but those are rare cases and case by case. A little bit of clinical adoption. It was FDA approved in July of 2022 for that BMI threshold. Since then, there's been national and international support for this procedure. Most recently, in January of this year, the American Society for Bariatric Surgery essentially endorsed it for a BMI 30 to 40, which is very appropriate for the level of weight loss that you can see on this as a standalone therapy. It now has a Category 1 CPT code since this year, and it's now covered by some insurances, and it's now even a covered benefit for our employees, Medicare, and many other commercial and self-insured programs. And I will tell you that even if patients don't have a bariatric benefit on their health insurance plan, with appeals and letters establishing medical necessity, we have seen up to 50% conversion rate since the CPT code come out, and that's new. So I expect over time that more and more of these insurance plans will have a defined benefit in their plan, approving these endoscopic bariatrics as an alternative to surgery or as an alternative to medications, hopefully in combination. Let's continue on with this case, another case. So this patient, BMI 38, again, diabetic, hypertension, it really wants the sleeve. However, while she prefers a non-surgical approach, she's heard that the surgical sleeve is more effective because it removes a gastric fundus. So these patients are smart. They're reading about it. They're getting on ChatGPT, Gemini, Claude, whatever new AI agent is out there, and they're reading about weight loss and how surgery compares to endoscopy. And question is, which hormone is secreted from the mucosa of the gastric fundus in periods of fasting to activate the hunger stimulating or orexigenic appetite centers in the brain? And the answer is ghrelin. You always remember ghrelin as the monster. The ghrelin is the one directly responsible, majority responsible for the appetite regulation in the hypothalamus of the brain. And one of the surgical advantages of the surgical sleeve over the endoscopic sleeve is that it removes the fundus, which is the area of the stomach that makes 80 to 90% of our body's ghrelin. And we showed in our studies that after losing weight with the endoscopic sleeve, our ghrelin levels tend to increase. So it really speaks to how the body is engaging these counter-regulatory measures with weight loss. The body's trying to have you gain weight. So that's one of the limitations of this procedure, is that we leave the fundus intact, and ghrelin production is almost stimulated with this procedure. So a novel approach now is that we can endoscopically devitalize the gastric fundal mucosa, decreasing ghrelin and also decreasing accommodation that in theory reduces weight loss even further. And we didn't think about this on our own. We borrowed it from the interventional radiologist who started to ablate the gastric artery that supplies the fundus, and they showed a decrease in ghrelin. And we said, well, why don't we just ablate the mucosa and see what happens? And that's what my colleague that I co-lead this bariatric endoscopy practice in Rochester, Dan Naselli, did fundal ablation, where we basically lifted the gastric fundus of the stomach, which is a little thin, and then create a nice safety cushion, and then we ablate it using APC, which we call laser resurfacing at times. It's done under 30 minutes under anesthesia. It caused them some scarring 6 months later, and ghrelin levels were shown to decrease 45% after the procedure, and that was also associated with diminished hunger, fewer cravings, and improved confidence in the ability to reduce cravings. And you can see here, just by the number of arrows, that after the procedure, the number of ghrelin-producing cells dropped down considerably after 3 months. When we looked at maximum tolerated volume of liquid nutrients, which is like a drink test, we saw that there was a 42% reduction in their ability to consume liquids just after mucosal ablation. And here we see some trichomes staining illustrating the fibrosis after the procedure in blue. So what did they do? They combined the endoscopic sleeve of gastric fundal mucosal ablation. In the ablate 1 trial, patients got the ablation first and then got the sleeve later, and they showed upwards of 20% total body weight loss at 1 year. And then they did both of them at the same time, and they saw the same greater than 20% total body weight loss at 1 year. And there was no serious adverse events with either study, showing kind of a proof of concept that the combination leads to more weight loss at 1 year. So what's the next generation is here basically at Mayo Clinic. We're doing this investigationally, but same day procedure. We just added both procedures in one, so it's a little longer, 90 minutes. Similar risk, similar recovery, similar candidacy profile as the endoscopic sleeve alone. We just add a little extra layer of antacids to minimize the risk of bleeding after the ablation. And we prefer patients ideally these patients are not on anticoagulation like long-term, such as Eliquis, Xarelto, or warfarin after this procedure, due to the theoretical increased risk of bleeding. I suspect in the future we'll know if it is safe to do on patients on anticoagulation, but at this time, we're only doing it on patients who are not on any. Again, so this is just a schematic again of how many options we have for patients nowadays when it comes to primary obesity. And feel free to use this as a reminder of all the options patients have. It's not just diet and exercise or just medications or just surgery. It's really a combination. It's been 45 minutes or so, I believe. So I'm going to go a little quicker, but this is case 2. This is a patient with obesity, had a Roux-en-Y 15 years ago, lost incredible amounts of weight. But she also regained a tons of weight, and now she has sleep apnea again and hyperlipidemia. She does not feel as full anymore. She wants to know what she can do. Would you offer a balloon, an endoscopic sleeve, a tori, mucosal ablation, or lengthening of the roux limb, or distalization of the bypass? So I'll tell you, intragastric balloon is not possible. Previous surgery is a strict contraindication. The endoscopic sleeve is not. A tori is the correct answer, which I'll talk about, the transoral outlet reduction. Gastric fundus mucosal ablation, the fundus is barely there, so you can't do it. And lengthening of the roux limb is a surgery, so it's not something she's interested in, but I'll tell you that we've done both a tori and this as an option to avoid switching to a duodenal switch. Roux-en-Y gastric bypass. Over 20% of these surgeries are performed across the U.S., although those numbers are declining. Incredible amounts of weight loss and completely remarkable rates of resolution, not improvement, of type 2 diabetes. However, 20% or more patients will see some weight regain over time. 1/3 will unfortunately receive complete return of their weight, no fault of their own due to anatomy. We know that the GJ anastomosis, or the outlet, also called the stoma, can dilate over time. And that increase in diameter is associated with weight regain in a linear fashion. And we know that the amount of excess weight loss, the old metric compared to total body weight loss, there is decreased amount of weight loss when we look at patients who have an enlarged pouch and an enlarged stoma compared to those who have a normal size pouch and a normal stoma. So there's an anatomical reason why these patients are gaining weight. And what we do is we do a transoral outlet reduction. This is an outlet diameter, it's really large, approaching 40 millimeters. We first do APC, or mucosal ablation, similar to what I showed you before in the fundus, but this is to induce scarring. We use that same suturing device. We do like a purse string suturing technique. We put a one suture going around like a purse, and we cinch it or tighten it over a balloon, and it's really narrow. And over time, look at that difference in size. And now patients have return of their feelings of fullness when they eat. It's FDA approved for patients with a BMI of 30 to 50 who've already had a Roux-en-Y gastric bypass. It is used off-label for dumping syndrome. There's no category CPT-1 code yet, but there's an ongoing clinical trial that we're part of to capture the CPT code. Ideally, we get patients who did lose weight but also experience weight regain. It's not really useful as much in patients who never lost weight, but it's still something that if the anatomy permits, we will perform. Importantly, they have to have a loss of satiation and satiety. Of course, they have to have well-treated eating disorders and well-treated substance use disorders, which can become quite common after previous bariatric surgery. What are the outcomes? You see a theme here, greater than 10% total body weight loss maintained for 3 to 5 years. Not surprisingly, it's also improved when we combine it with medications. Here's a trajectory of a patient that over a 13-year period got a Roux-en-Y, lost all the weight, we call the nadir, and then started to gain almost all the weight back, did a tori, and basically he stopped that trajectory, and she's down now to 17.3 total body weight loss at 1 year. Recovery, 1 to 2 days of mild bloating, cramping, risk for GI bleeds, infections, perforation, and thromboses are all still less than 1%. There is a concern for making it too tight, and the patients have to come back, and we have to dilate them once or twice, and usually they get better. In rare cases, we have to stent them temporarily, but the patients are quite happy. It's very hard. I'll take the last 10 minutes here to talk about diabetes. It's hard to talk about obesity without having touched on type 2 diabetes. There's over 400 million people worldwide that are affected by type 2 obesity, and that number is expected to rise to over 550 million by 2030. And roughly 80% of those affected by type 2 diabetes also have obesity or pre-obesity BMI range. just like obesity, type 2 diabetes is very hard to treat. Only about half of patients end up achieving adequate glycemic control for different reasons, either medication adherence, access to medications, or just difficult to manage. And we're seeing, unfortunately, an increase in hemoglobin A1C levels in young patients compared to those that are older, which is a striking just change in the pattern of type 2 diabetes in this country. And so while metabolic and bariatric surgery is still the mainstay treatment, the most effective, remember only 2% of those that are eligible go for it. Medications work in these patients. These medications were first used for type 2 diabetics. But patients don't lose as much weight if they have type 2 diabetes. So when we see here on the graph on the right, I'll show you that with semaglutide, the degree of weight loss with obesity alone is approaching 15%, yet for those with type 2 diabetes, it's only 10%. And the same thing is seen with tirzepatide. And I suspect we'll see the similar with the newer medications or retatrutide. And the patients also tend to decrease the use or discontinue it at 1 year, less so than obesity alone because they have other reasons to be on it, but it's still upwards of 25%. So as gastroenterologists, we get creative and we recognize the importance of all these organs, and the duodenum is very important for glucose homeostasis. It responds to nutrients after the stomach. It's involved in signaling. Hormonal and enteroendocrine cells are controlled for hormone release, gastric emptying. So all these factors lead to controlled glucose. When the duodenum is diseased from inadequate diet or excess glucose, the ability for the duodenum to regulate our blood glucose is disturbed. And we can see this now. Our cameras are getting better. Here I'll show you a healthy duodenum. Nice little villi, regular and homogeneous. There's uniform halo. There's like a nice pale halo and a nice solid red center. There's no signs of inflammation or excess fat or chyme. And here we see a more diseased duodenum in a patient with uncontrolled glycemia. Everything is paler, disorganized. They don't look as healthy. There's excess fat or chyle deposition. We can see that endoscopically. So when we resurface the duodenum, we can actually reset this duodenopathy that we call and improve glycemic control. And we're seeing that. So now we're doing Revita, duodenal mucosal resurfacing, which is a hydrothermal balloon. We ablate the duodenal mucosa and it regenerates into more normal. And there's also a non-thermal based therapies called the reset device using electroporation that we reset the duodenum. What is the data? Well, I'll tell you that we're seeing medication level improvement in A1C reduction. Here's a table of what the typical A1C reduction is with medications. Early studies show that both the thermal and the non-thermal devices lead to medication level A1C improvements at 6 months and a year. And this is after one treatment, one time. And it's pretty much relatively safe. Early devices there were some few perforations, but those were the early devices, and it's been completely improved ever since. And patients too tend to lose some weight with these medications as well. The reset device, which is electroporation, non-thermal, already has data that with the Generation 2 device, we're seeing almost 2% improvement in A1C at 1 year mark, which is incredible for a one-time use device done by an endoscopist. And the patients were not healthy diabetics. They had diabetes for at least 5 years. They were on 1 to 4 medications. They had uncontrolled insulin-requiring A1C levels, and we brought them down 2 points at 1 year. So what else can we use this for? Well, can we use this as a way this is the exciting part, to stabilize patients who are coming off medications. Recall that a lot of the patients regain their weight when they lose it, and so they investigated this. With the thermal-based older Revita, they found that patients who got the treatment when they discontinued the medication, patients only regained 25% of their weight compared to 75% of their weight when they got the ablation device, which is a way to stabilize the weight after medication discontinuation. And we're going to start to see more data towards the end of the year. So the future of metabolic and bariatric endoscopy will really have the ability as gastroenterologists to leverage the entire gut, or triple G. We can do gastric fundal mucosal ablation, controlled ghrelin. We can do duodenal mucosal ablation to control the glucose. And we could also do a restrictive gastric procedure by the endoscopic sleeve. And to me, the combination of these procedures will be the next wave of endoscopic bariatrics. Will make these devices much easier to use and safer to use, and will work in parallel with medications and perhaps save patients from needing surgery. So what do we do? What is the strategic integration of endoscopic bariatrics in this GLP-1 era? It's an alternative to medications. They don't want to start it, don't tolerate it. You can offer endoscopic bariatrics. If you're currently taking anti-obesity medications, they plateau, you can offer this as well. For those who are seeking the most amount of weight loss, you can do a priority combination therapy, endoscopic sleeve, and then wait 3 months and then try on a medication. Last couple of minutes, I'll give you some top 10 take-home points. Number 1, obesity is a chronic progressive disease, over 200 weight-related comorbidities. The response exists on a bell curve. Patients may need multiple therapies or just one. It may be sequentially over their lifetime, so it's a long-term process. Weight management requires a multidisciplinary approach, behavioral health specialists, dietitians, surgeons, endocrinologists, primary care providers, and GI doctors. They all need long-term nutritional aftercare. And we need to be honest and approach patients if they experience weight recurrence early so that we can intervene early. ESG, same-day non-surgical procedure, facilitates weight loss as an option or in combination with medications. You can see upwards of 15% total body weight loss with this procedure, upwards of 20% when combined with fundal ablation or medications. TORI, after bariatric surgery, is also another non-surgical endoscopic therapy to facilitate weight loss of upwards of 10% after doing gastric bypass. And these procedures are now increasingly covered by a number of insurances. You may have to appeal, but again, upwards of 50% approval. The next frontier is the duodenum, the first point of communication between the food and its host. It integrates, it's kind of the signaling hub for multiple responses to managing glucose control and metabolic homeostasis. This becomes a range, and we're starting to capitalize on it. We'll see if duodenal mucosal ablation can improve glycemia and weight loss, and it may have a role in stabilizing weight after obesity medicine discontinuation. Combination therapies that span the foregut, the triple G, so to speak, will be explored as we hope to achieve surgical levels of weight loss without surgery and perhaps even without medications as well. Thank you for your time. Here's a picture of Dan Maselli, Maggie Gemlin, me, and Catherine Swenson, who comprise our metabolic and bariatric endoscopy team here at Mayo Clinic. Thank you. I think I stopped my screen share. There you go. So I'll tell you that we're seeing a lot of more complex patients here now that are seeking further weight loss after GLP-1 medications, or they're coming off, and they're a little bit of a harder population to achieve weight loss after these therapies. Like if they've already lost 15% total body weight loss on a GLP-1, and we do the procedure, we're obviously not seeing as much of a weight loss from the additive procedure, but overall as a whole, we see that 20-25% total body weight loss, but it's not additive like 15 and 15%. We're seeing patients who didn't respond very well to medications at all, and we're still achieving 10 to 15% total body weight loss when we combine these therapies. So it's a way, an option for patients who are hesitant. There are some questions coming in. I see one here about vitamin deficiencies. I briefly touched on it. One of the key advantages about this procedure, and it may be to the velocity of weight loss that we see, I'll be honest, that we don't see nutritional deficiencies with these endoscopic sleeve procedures. We're not seeing that compared to Roux-en-Y gastric bypass or the sleeve gastrectomy, which doesn't have as stringent as vitamin deficiencies. When it comes to the reset and the novel duodenal procedures, we're not seeing any long-term nutritional deficiencies in our ongoing clinical trials based on the safety data in animals and early humans. We are not supplementing patients after they get ablated because it's a temporary ablation. The tissue regenerates, so there is not a long-term hypoabsorptive state that leads to deficiencies. Very important to first screen for any existing vitamin deficiencies, which can be common in kind of the sarcopenic patient with obesity that has a poor diet, because if you do these procedures, you may exacerbate a pre-existing kind of at-risk vitamin deficiency, but they don't require. That's a great question, though, about vitamin deficiencies and these novel therapies. The next question from Michael was, are new gastroenterologist trainees doing these procedures? Yes and no. So there's been a lot of industry support because in training physicians in doing endoscopic sleeves and tori procedures, because they recognize that without them providing the mentorship model across the nation and a structured training program, not only do existing gastroenterologists won't have the ability to do this procedure, but new GI doctors may not see enough volume in their, essentially they would have to do an advanced endoscopy fellowship or a bariatric endoscopy fellowship to get exposure. So yes, there are some new gastroenterologists doing these procedures, but not as much as you would expect. But with the increase in industry support and hopefully increasing insurance approval across, trainees will have more exposure and ability to pick this up. There's only a handful of bariatric endoscopy fellowships in the nation. And so industry has been very helpful partnering with existing or new gastroenterologist training with oversight, because we want to make sure they do these procedures well. So we volunteer our time to proctor and mentor when our own institutions allow to make sure patients are successful in getting these procedures. Some other questions that come up that I get from patients is pregnancy, and I tell them that as long as we wait 6 months after the procedure, there's no contraindication. We have used these procedure in patients who have difficulty conceiving, and so we honestly understood its safety by the surprise pregnancies that happened in the early procedures, and the babies and mom did really well. So now we're okay with mothers to be to get pregnant 6 months after the procedure. And other questions that we get are alcohol use after these procedures. So after bariatric surgery, you basically are supposed to cut off alcohol completely, because you've removed parts of the stomach, so the metabolism is different. And so while we're not removing parts, it's an anatomy preserving procedure. We tell them that it's not a strict contraindication. However, we do not encourage the use of alcohol from the calorie perspective, but also the higher risk for developing a substance use disorder after procedure, which is a phenomenon that occurs after bariatric surgery. And we're starting to capture what that level of incidence is, which thankfully so far low, but after the endoscopic sleeve. Other common questions that I get are related to exercise, and there's no strict requirements. Like, we're not making any incisions on the inside, so there's no healing from the inside that needs to occur. So patients generally can return to strength training, for example, which is very important. quicker than after a bariatric surgery.
Doesn't look like we have any other questions. So thank you for going ahead and answering some common questions you get. That was nice.
I'm sure there's more questions that I can't think of right now that are common by patients, but mostly it's related to recovery and alcohol and which I get, and pregnancy recovery, alcohol, and time away from work. And usually we just say 48 hours. Ideally, we do it on a Thursday or a Friday so they can recover home during the weekend and then return to work on Monday.
Perfect.
I'll share with you last little thing. What are the private pay? It really depends on where you get it done. But we've seen places that do it on cash anywhere from $9,000 to $15,000 to get the procedure. But again, increasing insurance coverage. So we're not seeing many patients having to rely on cash pay to get this procedure. Still much more affordable than if you were to do cash pay bariatric surgery in the US. I won't speak to medical tourism in Mexico, but it is also an option across the board.
Thank you so much for sharing all of that. I know that was a lot of information to cover in just like an hour, but I think you did a great job. I always send home kind of take-home points in an email. Is it okay if I share your email address for additional questions?
Of course, yeah. Feel free to email me. Please share if you have any questions or feel free. Happy to answer them.
Amazing.
Thanks again, everyone, for your attention, and I hope you took away at least something like 30 seconds worth to your patients.
Thank you so much again for your time. We appreciate it.
Anytime. Take care, everyone.
You
Thanks,
too.
Dr. Vargas.
Thank you.